During this process, we observe a shift from a trigger-based to a substrate-based atrial fibrillation, and somewhere, maybe at this point, we have the point of no return, where our traditional treatment, like PFA or radiofrequency, may fail. The challenge, therefore, is to intercept the onset of electrical remodeling before reaching this irreversible point. But what is exactly electrical remodeling? In our research published in 2022 on JACC-EP, we aim to pinpoint the beginning of electrical remodeling. The aim was to quantify and to visualize these electrical changes before they become irreversible. And here you see analysis performed during sinus rhythm in patients with paroxysmal and persistent atrial fibrillation showed that the more you go towards persistent atrial fibrillation, the more numerous and dense are the slow conduction corridors, which are these stents and blue lines. And in our study, we also exported this patient to analyze what is the pivot. The pivot is an old-fashioned phenomena, which in this setting of picture are represented with the blue or red points in where the wavefront turns clockwise or counterclockwise. And one of the most important findings from our study is that in most cases, these electrophysiological phenomena were invisible to our standard bipolar voltage maps. This suggests that we might need to reconsider how we use voltage maps as indicators of abnormal conduction. This brings us a crucial point. If we wait until structural abnormalities become relevant, their remodeling may be already irreversible. The real challenge is to anticipate and design treatments that target the functional EP phenomena that sustain atrial fibrillation before we reach that critical threshold. But what are the other mechanisms? Everyone agrees that paroxysmal atrial fibrillation is triggered by localized firing within the pulmonary vein. But what if this PV trigger also induces other electrophysiological phenomena due to its high frequency? If we build a graph plotting conduction velocity against the rate, it's not a surprise that AF ends up in the right corner. AF has the fastest rate and highest conduction velocity. VT and AT, on the other hand, have slower rates and conduction velocity. This means that atrial fibrillation is very prone to functional phenomena. But what's functional phenomena? It's something dynamic, which depends on several factors: rhythm, rate, directional wavefront, and anisotropy. And so I think the key is to link the sinus rhythm to atrial fibrillation, and we learned this from VT. In fact, the lines of block in slow conduction corridors appear during VT, but don't necessarily exist during sinus rhythm. This brings us to make this multi-center study, is the functional substrate mapping. And here you see, this is a cartoon mapping system, so simultaneously mapping. The first one is during sinus rhythm, and the second one is during an atrial excess stim delivered from sinus, coronary sinus. And you see here, you have two high-density, super high-density mapping with the octarray, and you have simultaneously two maps, one during sinus rhythm and one during the pace excess stim. So actually, it's not straight pacing. It's just an excess stim delivered every 3 beats from the coronary sinus. And this is an example of what we call fixed phenomena. You see here on the left map, during sinus rhythm, at this site, there is a slow conduction line of block on the anteroseptum. And this is confirmed during the pace map. You see on the pace map, the same area is highlighted. So, and also the bipolar maps, the two bipolar maps shows the same disease. So this is a fixed phenomenon. Indeed, in this example, you see at that point on the posterior wall, just below the right inferior pulmonary vein, you have an example of a slow conduction phenomena. You see there is a late activation map, and on the CS pacing, there isn't. So there is a fast-forwarding wavefront. And this is our protocol. You see, there are the first 2 beats are during sinus rhythm. So we deliver an excess stim from the coronary sinus, from the distal coronary sinus. And you see here an example of a normal conduction. So the EGM looks identical to the previous one. So this means that there is so the timing, the duration, the amplitude is the same. Indeed, when we are on an area of slow conduction, PIVO, when you deliver an extra stim, so here we are in the same patient but different site, you see there is a S-type response with different timing and different amplitude and also fractionating occurring on the pentarene splines. So this means here something occurs. And here an example where structural and functional phenomena occur simultaneously. Here you see an example of a fixed phenomena. You see a very heavy line of block at this site, and also the bipolar map shows the same. But look what happens when you deliver an atrial extra stim from the coronary sinus. The first one is confirmed, but there is another one here just below the left inferior point vein that appears. So in this patient, two phenomena, one functional, one fixed, appears. And look, this tiny signal. At this site, I was able to highlight this very late potential activity like in VT. And when I pace from the pentarene, you see atrial fibrillation starts. I don't know the meaning of that, but it's very interesting. So the main finding of our study, recently published on Heart Rhythm last month, shows that in 63 maps, 63 patients enrolled, paroxysmal and persistent. We were able to describe 234 conduction abnormalities, of which 53 were functional and occurred mainly during sinus rhythm. And the anterior wall and the posterior wall, the sites were during sinus rhythm, we highlighted more functional phenomena, while during extra stim, indeed, were at the PV atria. So the main finding of our published manuscript was that AF recurrence are predicted by functional phenomena. As you see by this on this Kaplan-Meier curve, if you have one functional phenomena residual after PVI, so if we included in our WACA, in our wide atrial circumferential ablation, one or more functional phenomena, the recurrence rate is very high. Indeed, when with our WACA we left, so residual functional phenomena, the recurrence rate is higher, especially in the persistent group. But another finding, very interesting, was the relationship with anatomy. Here you see the sinus rhythm activation, Bachman, the left atrium is activated, and you see what happens here. There are two areas of slow conduction activities at these sites. You see, the first one is here, and you see also there is a convexity here of the left atrium, and if you overlay the CT scan, as we did in every patient of our series, you won't be surprised to have at this site the aorta. And also on the posterior wall, you see this is activation map of the posterior wall during sinus rhythm. Look what happens here. There is something tubular, something that you can clearly recognize. Here, something tubular shape, and if you overlay the CT scan, here there is the esophagus. And again, the bipolar voltage is completely normal. And this is another example, sinus rhythm activation. Look what happens to the left inferior point vein at this site, another area of late activity, slow conduction, and here there is the esophagus. So in conclusion, our research suggests that in patients with both paroxysmal and persistent atrial fibrillation, there are abnormal conduction areas that are easily displayed with high density mapping and during sinus rhythm. However, only analyzing with a comparative analysis, so of pace and sinus rhythm, you can highlight the structural and functional phenomena of abnormal conduction. Residual conduction phenomena, functional, after PVI predicts AF recurrence, and aortic root and esophagus may play an important role in the genesis of areas of abnormal conduction. I think we should go beyond PVI and low voltage areas to identify ablation targets that prevent AF progression or the so-called electrical remodeling. Thank you.